And also just to preface, Dr. Bishop and Dr. Rossano, I'm going to be recording so that we can upload it to our YouTube, so more people could view it in case they weren't able to make it. So I'm going to start off now. My name is Emiliano Juarez, and I am one of the co-programming directors for Medical Marvels. Medical Marvels is a nonprofit global organization that promotes medical literacy and awareness for pre-health students. Since 2020, 1,100 plus members have joined the Medical Marvels community, which spans across 30 plus countries, and the numbers only continue to grow. So just gonna talk a little bit about setting up events and also just like in the future what we're gonna be doing. So as like a co-programming director, we help set up and facilitate events for the Medical Marvels community. And we've been reaching out to doctors and have successfully set up 5 events with this last event being the 5th for this year. And so we've had previous events with the Texas chapter of the American Red Cross, Dr. Sunder, who specializes in psychiatry, and then Dr. Noble, who also specializes in cardiothoracic surgery. And then today we will be learning more about cardiology. So I'm going to pass it off to Dr. Bishop and Dr. Rossano to introduce themselves and also introduce the work that they do.
Well, my name's Warrick Bishop. I'm a cardiologist based in Hobart. I work principally in private. My purview has been general cardiology, but in the last few years, I've really pivoted towards preventative cardiology. I deal with adults. I don't do children. That pivot towards prevention has really been born out of a realization that we can be proactive at reducing risk of heart attack. So my areas of interest these days are really around lipid management and imaging the coronary arteries, and that forms a large part of my practice these days.
Dr. Rossano?
Yeah, hi. It's nice to see everyone. Thanks for joining. I'm Joe Rossano. I'm a pediatric cardiologist in Philadelphia, in the United States, and I work at the Children's Hospital of Philadelphia. And so it's even though it's dealing with the heart, it's I suspect my practice and our practice quite a bit different than Warrick's practices. For the most part, we treat children that are born with what's called a congenital heart disease. So their heart didn't form entirely normally when they were developing, and that's left them, with some problems. And there's a variety of treatments that we have for it. Some of these are pretty minor. Some can be pretty severe. My personal practice, I care for those children, but I also care for children that have heart muscle problems and develop we call cardiomyopathies and heart failure, and if they need a heart transplant, then I'm involved with the care of those patients. I'm also involved with research in these areas, and I'm our chief of our division of cardiology. So I have a kind of a supervisor role of our group and how we kind of manage our health system. And so, yeah, I'm happy to answer, any questions you have. But I just sort of preface it to say that medicine in cardiology in particular is an incredibly diverse field, and so the kind of work people or in operations, and so it's just it's a great field, and I have a certain lens of that, but it's very, very diverse.
Awesome. I just wanted to let you know that you did cut off a little bit, but it's okay because you could explain more about all that you do. So I'm gonna be getting into the first question now. So Dr. Bishop, you can answer this first, and then Dr. Rossano, you can follow. So how did you become interested in cardiology, and what inspired you to pursue it as a career?
Look, to a large degree, I fell into cardiology when I finished my physician training, which is what we do in a general as a foundational step for our specialist training. You tend to go through different rotations and experience different things. The very first thing that I did was hematology. And at the time, this is back in the 90s, they were just identifying cell markers and they were treating hairy cell leukemia with retinoids. And this was mind-blowingly exciting. I can see Joe nodding there. I found this stuff prickling in terms of how impactful it could be. And working on the hematology ward, there was always something happening. There were low platelets, there were bone marrow transfusions. And I thought, well, this is for me. I went to the grand round, of course, on a weekly basis. And as they were sharing the pathology slides on the big screen and talking about the H&E staining and the degranulations, etc., the magenta hues, I realized that my color blindness, which hadn't ever played a role with anything, would completely preclude me from doing hematology. So I really had the chance to work through a number of different other areas. This is an honest sort of environment. So I found that respiratory, I couldn't deal with people coughing up regularly. Sputum was something that I couldn't face every morning on ward rounds. I didn't think I could genuinely ask people about their bowel habits on a regular basis, so I moved away from gastroenterology. Neurology, I thought was fantastic. I developed a beautiful skill set in the neurological examination, which is almost like a dance. But I remember a fabulous grand round we had with the professor who demonstrated a case on a young woman, and it was some sort of deposition of iron in the brain. Put up my hand and asked, what's the prognosis for this person? What's the treatment? And the professor said, oh, there's no treatment. It's just interesting. And my heart sunk thinking, gosh, I don't think I can deal with a specialty where we don't have answers and don't have the ability to help. At the time, rheumatology was in its early forms, and all we really gave people were large doses of steroids. And I found that terribly depressing. Lo and behold, I dropped into cardiology. That was the era of streptokinase. We were opening arteries. We were giving people ACE inhibitors because that was the time when the cardiac failure trials were coming through. We were doing balloon pumps in ICU, coronary care. We were dealing with rhythms. We were actually saving lives and getting people out in the street. There was no requirement for my to identify colors because ECGs weren't in color and neither were echoes or angiograms. And it was the perfect place for a colorblind physician. So I dropped in there, and believe it or not, I ended up at a sponsored event a couple of years ago, only to find that out of the 10 people who were all cardiologists sitting at my table, 7 of them were colorblind. So I dropped into cardiology, and I have to say, it was wonderful. It gave me an opportunity to be impactful. I really enjoy the patient journey. And I haven't looked back really. Over to you, Joe.
Yeah, that's great. A different journey, but also did not think that this is what I would do when I, went to medical school. I grew up in Arizona. I'm not sure where everybody on the call is from, but if you're not from the United States, it's in the Southwest, and it's a pretty rural state. Couple cities, but the rest of the areas are pretty rural. And I thought I would be a kind of a general doc, family type doctor working in somewhere in rural Arizona, and that's just kind of what I pictured a physician to be. But then when I went to medical school, we had a very kind of traditional teaching that was kind of organ system based. So you'd spend some time on the lungs, on the kidneys, and then, when we got to the, cardiac physiology, I was just fascinated by it. And certain things like, renal kidney physiology it's complex. It's sort of hard to understand, or at least for me, it was hard to understand some of that. It wasn't very intuitive, but the heart and the cardiovascular system just made more sense to me. And the heart's a pump; it pumps blood, so it's not all that complex, at least in some of the concepts. Some of it can be very, very complex, but but the physiology of kind of how the heart and the cardiovascular system works, I just thought was fascinated, and I'm still fascinated by it. And then as time went on during medical school, and you get exposed to patients and different diseases and how they are treated, I was really just drawn to caring for children and their families, and I just found it to be just incredibly rewarding, and to be able to help hopefully make a positive impact on these families' lives was really kind of what brought me into pediatric cardiology. Though I did for a while think about adult cardiology, which just hearing you talk about all the excitement in the 90s is just reliving that. It really was an incredibly exciting time. A lot of new discoveries were happening, and just feeling like these intractable problems that lead to a lot of early death and a lot of sickness, that there were real hope on the horizon. So it's anyways, it's been a great field to be a part of.
That's awesome hearing both of you talk about that. So I just wanted to ask a follow-up question about your work specifically. And that is, like, what are some common heart conditions that you encounter, and how do you typically approach their diagnosis and treatment?
Well, I'll kick off, I guess. It seems to be I'll go first and then Joe has a go. Look, we would overlap very little. I don't do congenital adults, too complicated for me. And there are specialties, there are specialists now in the field who are picking up the children that Joe looks after. As I said before, my real area of interest has become and pivoted towards prevention. So these days, to a large degree, I try and see well people who might be at risk with high cholesterol or concerning family history. For those people, we're dealing with coronary artery disease, and really the very best way to evaluate what's going on in those asymptomatic individuals is to image the arteries. So I use a lot of cardiac CT imaging to evaluate what's going on in their arteries, and then put in place an appropriate strategy. Of course, because I'm dealing with adult medicine, I see things like hypertension and the consequences of that, which includes cardiac failure, atrial fibrillation, see palpitations, rhythm disturbance, and of course see people who have the manifestation of coronary artery disease, which is anginal type syndromes, and the requirement to manage them through that process. So they'd be the main things that I do. But I will say, as an aside, what I've also done in the last couple of years is generate a real interest in educating patients and providing resources to help them through their journeys. And we might touch on that later, because I did put together some resources for Medical Marvels and your members that you may well find very valuable.
So what that's it. Just want to just comment. It's so interesting, and just for folks to put in context of like the heart disease is the greatest killer worldwide, and a lot of it is preventable. And so the work that Dr. Bishop is doing is so critically important. And as different individual societies, as they move to become more industrialized, the incidence of heart disease just goes up. A lot of those are kind of lifestyle based and other things, but those that we can prevent so much of that, and so that work is so critically important. But a couple things that the way we treat patients, the way I come into the diagnosis of them now in today, and certainly in advanced system, United States, Australia, many parts of the world, most forms of congenital heart disease can be diagnosed before birth, with ultrasound, with fetal scan. So in our region, we're able to diagnose, especially most very serious forms of heart disease, during pregnancy. And so then that gives us the opportunity to counsel families, which is, very oftentimes devastating news if it's a really serious defect, and can be very hard on families, because that's just not what you're thinking about when for most people, if they were trying to have a baby, it's just incredible excitement. You envision a healthy child, and then to hear there's an issue, is really, difficult. And so we have that opportunity to really work with families and make a plan about how we're going to manage that, well ahead of time. And it's amazing, but we actually get it right most of the time, even though these are really small things that we're imaging. Many of these things we diagnose are not serious, and kids, are going to be just fine. But for a good number of them, they'll need surgery or a cardiac procedure, at birth. And so we'll make a plan, and if it's a serious problem, we'll actually deliver the child at the children's hospital, and then we'll treat them afterwards. And then the other side of that, as I am involved with children that have been healthy their whole lives, but then can get sick with their heart. Oftentimes that's from an infection or some other problem that manifests, and those children can get very sick from that, and oftentimes we're diagnosing them in our intensive care unit. And these are also things that are very hard for the patients and their families if they have had a healthy child or they thought they've had a healthy child for years, and now their child's very sick with a heart problem. Now, fortunately, we can treat most of these effectively, but that experience and that opportunity to be able to really help families through these really trying times is really one of the more rewarding parts of the job. And in most of the time, again, having the child do well and being able to restore health is really incredibly gratifying.
Thank you for your insights. For the next question, I just want to go back to both of you like agreed upon in the 90s, like when the technology was like really there. So I wanted to ask a question about how like technology has evolved in cardiology during your career, and like what impact has it had on patient care?
Yeah, I
Happy to
can
go.
start this time if you want.
Yeah, love you to, Joe. Go for it.
For us, technology has been incredibly impactful. I start talking about these fetal echo, cardiography, and that's really revolutionized the field. When I was a fellow, so that's after kind of our training in general pediatrics, I did, specialized training in cardiology. It was very common that a 2 or 3 day old or 5 day old baby would come into the emergency room critically ill from a heart problem that we didn't diagnose, that then manifested right after birth. And because the technology has improved and our ability to diagnose it, it's so rare that we see that today. So that's been a tremendous benefit. And then other ways for us to image the heart with things like MRIs and CT scans that Dr. Bishop had mentioned, has really been so valuable to us, because we used to have to do very invasive procedures and try to make plans about surgeries and other things based on not perfect information, which you could imagine you don't want the surgeon going into doing a complex operation and being surprised. You ideally would like him or her to know exactly the way things look, and so that those technologies has just been incredible. And I'd just say the other major technological advancement, which there's been many, but just one more to comment on, is for these congenital heart defects, now so many of them we can treat without a surgery through catheter-based procedures, and that technology and devices that we have, we can now close a vascular defect called a patent ductus arteriosus in a 400-gram premature baby without surgery, which is just, I would have thought unthinkable 5 years ago, and now we're doing it routine.
Well, from an adult cardiology perspective, obviously some of those technologies that Joe just alluded to overlay. So imaging has been huge. The quality of our echocardiography has got better and better and better. We talked about the 90s, so I'm going to use that as a reference to now, and that 30-odd years of an explosion of opportunities for new therapies and technologies. So the imaging, ultrasound is far more powerful. Cardiac MR imaging is really it's becoming a gold standard for things like cardiac failure, tumors of the heart, aortic assessments. We use PET scanning as well, looking for inflammatory processes within the heart, including infections. Stenting has become more and more advanced. So back in the 90s to the 2000s, we saw balloon angioplasty that was opening the artery, but often 20% of the time it had just closed down. Then they developed a scaffold to sit in there and hold the artery open, but the arteries in many cases would still grow back 5–10%. And then they figured out putting some sort of drug-eluting coating on that stent, something that would stop regrowth of the vascular smooth muscle within the artery, would lead to improved stent patency. And the delivery systems for these have improved as well. So we now see acute angioplasty as the recommended treatment for a myocardial infarction. And that's super cool when you think about it. That's pretty top-end technology being delivered within 30 to 60 minutes in most major centers in most Western world countries. We've also seen an explosion, as you alluded to, Joe, in structural heart disease and percutaneous interventions. So Joe was talking about closing off a patent ductus. In our world, we've got aortic valve stenosis, which is now being fixed up by a tube up the leg and a quick procedure, which allows the patient to go home the next day. It's really evolved over the last 5 to 10 years, but is now becoming routine, which is quite incredible. Talking more about devices, the complexity of the technology for the pacemakers that we're now using is incomprehensible. These things are as clever as probably any moonshot computer system from a decade or two ago. These things are really powerful. They resynchronize heart. They can restart the heart. They're defibrillators. The adjustments are just phenomenal. So our devices have got better and better, and we're even getting to pacemakers that can be planted directly into the heart and sit there without any wires whatsoever. Surgical techniques have got better and better, as have the sort of processes of recovery through coronary cares and ICUs post-operatively. And in the area of medicines, we've seen growth in that space as well, with an improvement in the sort of therapies that we see for cardiac failure. We've got a number of therapies that have come online in recent times, but the really interesting stuff are the things like the monoclonal antibodies we use. And in the space of cholesterol lowering, we've got monoclonal antibodies against receptors on the liver cell, which inactivate that receptor and help lower cholesterol. So these monoclonal antibodies are really quite a leap in the therapeutic armamentarium. Beyond that, we've now got small interfering mRNA molecules, which are allowing us to deliver a therapeutic shot once every 6 months for lowering cholesterol. And I imagine it's only a matter of time before we see DNA CRISPR technology allow us to target DNA, the DNA of cholesterol manufacture, and literally cure someone for life. And there are trials currently in primates running, looking at DNA therapy for cholesterol lowering. So there's an amazing amount of stuff going on in the world of cardiology.
Amazing. And also, just because like I don't know so much about it, and maybe like a lot of people don't as well, like on the Zoom as well. Could you, Dr. Bishop, explain what CRISPR technology is? I've heard a little bit about it, but could you just like elaborate more about specifically what that is and like the definition?
Well, I don't think Joe's probably better at giving the definition than me, but my simple understanding of it is it's a tool that allows us to target specific regions of DNA and basically cut or edit those sections of the DNA. And that is allowing us an opportunity to, if you like, edit that template and alter the sort of protein synthesis that drives the end product that we're trying to influence. And in cholesterol, it's things like a PCSK9 protein that sits on the liver cell. So if we can identify that, CRISPR is the technology that allows us to slice and edit in that correct area. Would you like to add to that, Joe?
Yeah, I think that's exactly right. And this whole area of gene editing and gene therapy is, in my opinion, is really one of the most remarkable advances that we have. And so when part of the diseases that I treat are these things called cardiomyopathies or heart muscle disorders, which each individual one or cause of it is rare, but in total they're not that rare. But they're frequently caused by a gene that's abnormal. And if there is and there's many ways genes can be abnormal. One way is that there's just no functioning gene at all, in which case, or no functioning gene, no protein that's made that's functioning, where gene therapy can be very helpful, where a vector, oftentimes a viral vector, is infused into the body and it goes to the heart and it replaces that gene. And so then the heart has that gene and it will make that protein that it doesn't have. And we're involved with a study right now of a gene therapy for this rare but pretty devastating cardiomyopathy called Danon disease. And there's no functional protein. And so this gene therapy seems helpful. For other genetically based problems, the gene is abnormal, but it makes protein, but sometimes the protein is overactive. And so some other forms of cardiomyopathy can have that, in which case gene therapy isn't necessarily a good, because you'd be given more of a protein, but they already have an overactive protein. And so in these scenarios, CRISPR-Cas9 is thought to be better. And those studies are still mostly in the lab, or they're not quite made it to to real world use yet, at least as far as I'm aware. But that's pretty exciting, where they can say, okay, well, this part of the coding of the gene is abnormal, so we're just gonna basically snip it and have it put in the right code there. And so that's really exciting. And for these what are called monogenetic, meaning it's a single gene, that abnormality that's causing a disease of the heart or elsewhere, it's just incredibly exciting now that we have these very promising technologies. And for certain diseases, it has revolutionized it. I mean, these were, there's a disease for, it's causing blindness that is much, much better now. Some very serious neurological diseases are incredibly better, with these gene therapy treatments. So it's it's incredibly exciting, and I think we're just starting to see these in real world use, and there's the potential to help a lot more people with them.
If I could add just an afterthought, one of the areas I didn't mention, which I think we may well see, is the use of pluripotent stem cells, or even specifically driven stem cells. I've not seen a great deal of research in recent time, but I know a fair bit has been bumping around. Do you know much about that, Joe? Because I suspect we'll see, particularly for the adult population who may
need... And we've done a little bit in children with some of these bad congenital problems, where we've taken stem cells from the umbilical cord and then infuse them back in at a later time. And I think it's probably still too soon to know how effective that is, but yeah, these kind of cell-based therapies are really, it's great technology. It's all very fascinating. But the how it goes from people studying the mechanisms of how these work, and then can we try it in an animal, and then can we get it to people? It takes a lot of incredible work, but when it works, it's incredible.
I think, I mean, as you look at these advances, you get the sense that we're moving in a way of nearer and nearer to smaller and smaller points of intervention. Of course, surgery or very, macro interventions are where we started with all this, but we went to neurohumoral changes and regulators and monoclonal antibodies, and we may well deal with cells, then we'll deal with mRNA and then DNA. So we're really driving down. We may even see impact on mitochondrial function. I don't know, but that's probably central to some of the stuff I see in diastolic dysfunction for adults. So watch this, but even mitochondrial interventions may be on the horizon. Who knows?
That is like so interesting. Like that is so exciting. And I'm like just wondering about in the future, like 50 years from now, how everything is going to be changed. So very interesting. On to the next question. Um, can you share a memorable success story where early intervention or innovative treatment made a significant difference in a patient's life?
You should be the master of that, Joe. You save lives in unborn children. So I'll let you
Yeah,
pick.
I mean, it's when we can diagnose a problem like these congenital heart problems before birth, it's such a game changer. I mean, I can remember caring for children that we did not do that and by the time they got to our hospital, we the too much damage had been done that we weren't able to save the child. And that's obviously devastating when you think like we could have had a therapy that could have made a difference here, but we just didn't diagnose the problem ahead of time, didn't institute the therapy when we needed to. And so having seen that it'd be 180 degrees different today than it was when I started in the field. It's been incredible. And for most problems that we deal with in medicine, not all, there are some problems that we just don't have good answers to. It doesn't matter when we diagnose it, the outcome is going to be the same, at least today. But looking for the next generation of you all to figure out ways of doing it better. But for most of the things, if we can pick it up early, we have such a better chance of doing well. And I'm sure Dr. Bishop would come in with coronary artery disease and so how important that is, and to treat blood pressures and cholesterols before somebody has a heart attack is so much better than afterwards. So yeah, it's really important to be able to do that.
Well, I can certainly echo that. I've got a story of a 46-year-old male who I saw about 18 months ago, who came because he had raised cholesterol and wanted to check what was going on. This 46-year-old male lives very close to where I live here in Hobart. And in fact, in the weeks literally leading up to when we had our consultation, I had been surfing with my kids and he with him with his kids on the same surf break. So we were near neighbors in the area that we live and surfing together. He came for a scan. We identified severe plaque in 3 major arteries, and subsequent testing actually demonstrated significant ischemia. This gentleman went off and had triple bypass and is now fit and well. Now, as Joe says, the opportunity to be forewarned just creates a different universe. But I was going to share one other story because Dr. Rossano, myself, anyone who's in the game of medicine, particularly in cardiology, where our whole job is making a difference on people's lives. So there's always clinical stories of making a difference, and that's an absolute privilege. So I wanted to take just 2 seconds, if I could, and share a story that's more about the patient than the disease, because they stick in your mind. And the reality is, although we deal with these diseases and these great technologies, if we're not connecting with the patient, then nothing actually happens. And Dr. Rossano, you not only have to deal with the patient, but the parents and the anxieties around them. They're they're big issues to deal with. So a very quick story, a number of years ago, I had a guy come and see me who was about 55 years of age. He came into the room. You guys will know exactly what I'm talking about, but the temperature went down about 10 degrees. He was frosty. He was angry. He was wearing a sort of a muscle shirt. You could see his tattoos out from under his arms. Had a packet of cigarettes under the t-shirt. And, you know, he was really, he was radiating anger. You know, how you going, mate? Oh, no good, you know. I said, well, you know, why are you no good? I don't want to be here. I said, well, you know, I didn't ask you to come here. Why are you here? He's like, oh, GP made me come, you know, this or this. I said, well, you know what happened? He said, I had a heart attack 10 years ago. I don't want to see doctors. I don't like them, right? So a couple of minutes of this, I took my pen and I put it down. I said, mate, I don't know you. You don't know me. I don't know why you don't like me, but I have to tell you that your sense of anger towards me is really uncomfortable. If you don't want to be here, that's cool. You can walk out just as you walked in. If you'd like to stay, I would like to help you, but you got to just change that. You just got to calm down a bit because you're really upsetting me. Anyway, the guy stayed, right? And I thought when I saw him, I'd never see him again. So I did this really long letter with about 6, 7, 8 points on a recipe for the GP to follow. You know, do this and then try that and then do this and do that. Now, remember, the guy hadn't been seen for 10 years by a doctor. And his backstory is obviously he was scared because that fear really drove his anger. Now, anyway, I said goodbye to him. He went. We weren't, it wasn't really a warm, fuzzy consultation. But lo and behold, 3 or 4 months later, I walk into my waiting room and the guy's sitting there. And I look at him. He smiles at me. I say, mate, I didn't think I'd ever see you again. How come you're here? He says, Doc, you made me feel so much better the last time. I thought I'd come back again. So for all the technology we've got, there's such a requirement for us to be able to deliver it to our patients. So I wish someone had given me that story when I was at your stage and your listener's stage.
Yeah, that's great. I couldn't agree more. It's it's the connection with the patients and for me and the patients and their families that's so important. And you can have all the right medicine and all the right plans, but if the patients don't believe you, they don't trust you, they don't trust the system, none of that matters. And so or they can't get to the clinic. There's all sorts of reasons why, even if you got a good therapy, you may not be able to, deliver it and have the outcome, that you'd like. But it's really that being able to connect with people that makes it all happen. And that's a great story.
If you want a little saying I use, Emiliano, it's and for your listeners, it's people don't care how much you know until they know how much you care.
Very interesting. I've never heard of that, but it's very interesting, and I like your story as well. It's pretty funny. So this is a question that both of you can answer. How do lifestyle choices such as diet and exercise affect heart health, and what recommendations do you often give to patients in this regard? Dr. Bishop, you could start. And also, if we don't have any questions at the end of both of you answering this one, then I'm going to continue with another question. But I think these last two would probably be it for tonight. And then I would just wrap it up.
So diet and exercise are critical. I'm happy to speak to this because it really does fall under the banner of coronary artery disease, and I, of course, have to be across it in the context of prevention as well. I think no one would argue that good lifestyle, good diet, regular exercise, these are all incredibly valuable components to general well-being as a very starting point. But I think we often get a bit confused and get caught up on them in a disproportionate way. And the reason why I say that is in the space of prevention, I get many patients who might say something like, oh, well, I eat well, or I exercise regularly, therefore I should be okay. And I think it's really important to understand that lifestyle choices are supportive of your health journey. They're not a guarantee of your health journey. And if I could put that a different way, if we took 1,000 people who exercised well, who ate well, who didn't get too stressed, who looked after their blood pressure, and we compared them to 1,000 people who didn't look after themselves, didn't look after their blood pressure, etc., then in that latter group, more people would die. No question. I have no issue with that at all. But the concerning bit that people don't get is that even in the healthy cohort, people will die, just not at the same rate. And so we've got to disconnect this belief that our associations with better health are causative in the process of coronary artery disease. I don't believe they are. The process of coronary artery disease is more complicated than just diet and exercise. They're important components. I'm not diminishing them, but I think it's most important to actually look at the final common denominator. And that's because the arteries are all unique in terms of their anatomy, where the twists and turns are, where cholesterol plaque may build up because of shear stress in that particular person's anatomy based on, how it tracks around the heart. There may be variances in the proteins and therefore changes in the charges of the lipoproteins that carry the cholesterol particles around, and these may stick or not stick depending on genetic factors that we're yet to fully understand. So as much as lifestyle, diet are important, and we talk about Mediterranean diet, and we talk about 5 sessions of 30 minutes a week, all this is blah and really important. We should all do it if we can. They are not the foundational stone of prevention. The foundational stone of prevention is really looking and seeing what's going on in the arteries, in my opinion. Over to you, Joe.
Yeah, I don't think that's great. That's a great point of and some yeah, that's a great point, and like there are like having a genetic predisposition to high cholesterol is actually pretty common in at least in the US. I presume worldwide. I don't know, but I presume that's not just the United States. And so like, people may feel like, they didn't do enough, they didn't exercise enough, they didn't eat enough, but some of it like just kind of how they were born, you know what I mean? They have this predisposition. And so it's still good that they exercise, but that, it's just not going to be enough for everybody to sort of prevent that, which is why you should, get your cholesterol checked and, these other, things are important. I would just say, the only thing I would add is that, these are just all of the antecedents of, these, most cardiovascular disease that affects people when they're 40s, 50s, 60s, 70s starts in childhood. And so, it's really, it's important to, keep that in mind, with young people, that their lifestyle choices, then they're even paying attention to their cholesterol at young ages, which is now recommended to get screened, is really important, because it can, you can make changes and do things when somebody's 5, 10, 15 that can be really important for them. So they don't have a stroke when they're 35, which is obviously devastating.
Look, if I could speak to that for a moment, there's no question that people with high cholesterol and a family history, which end up being diagnosed with familial hypercholesterolemia, and there's genetic testing for that. And we look at their LDL receptor and their PCSK9 genetic status, and these things, these people with this family predisposition and the genetic makeup for premature coronary disease, as Dr. Rossano says, really benefit from early treatment. But the flip side is I see people with, modest elevations of cholesterol. And some of these people have terrible arteries, but some have really clear arteries. And yet I see people with low cholesterol and clear arteries, and I see people with low cholesterol and terrible arteries. And separate to that group of familial hypercholesterolemics, who I think we would all agree need to be treated aggressively, and I agree with Dr. Rossano there, there's this real complexity around what must be occurring. And cholesterol and the way it's transported and the way that person has local factors that we fully don't understand continues to be a bit of a mystery. And I still really strongly advocate that imaging and looking at the final common denominator, which is the arteries, is the safest and most effective way to figure out what's going on.
Good.
It looks like we have a question from Elliot, and then Shania, you can ask your question after. So yeah, go ahead, Elliot.
Hi there, my name's Elliot. I'm a senior in immunology at the University of Texas at San Antonio, and I also do research at Long School of Medicine, also in San Antonio. But I was curious about what y'all thought of statins and the blowback against them that's been happening recently, at least in Texas, maybe, because I've been seeing a lot of people complain about rhabdomyalgia and some of the other side effects. I'm curious what exactly y'all think of that.
Would you like me to do that, Joe?
Yeah, I think that's right up your alley. Yeah.
I reckon I do more statins than you do. It would be my guess. Look, Elliot, in fact, it is in my purview. I deal with people with statin intolerance and perceived statin intolerance all the time. There is no question that we have no drug that is completely without risk of side effect. Every drug has a risk of side effect. And I think what we have to recognize is a number of things. One is there's a lot of social media stuff that drives people's perceptions about statins in particular and cholesterol. So they've muddied the water. They often don't present the whole story. They present a little snippet of it. A bit like a dating site might have a rather fudged picture. And then people get attached to that. So there's a lot of mischief out there with people who have a bit of an agenda, and unfortunately they don't share the whole story. I think, as I said before, cholesterol levels of their own, when people come to me and say, oh, cholesterol's not the problem, I say, look, I agree, because we see people with high cholesterol, bad arteries, high cholesterol, good arteries, and so on. So cholesterol of its own isn't a great predictor, and treating cholesterol per se, I don't necessarily do it. So I'm able to agree with these people. I say, but what we do know from 25 years of robust, randomized, double-blind control studies is without question, if we find people who are high risk and we lower their risk, every millimole reduction, regardless of whether they start at a high LDL cholesterol or a low LDL cholesterol, we give them a 20% relative risk reduction. We now have data that tells us for high-risk patients, and remember, high-risk people are people who've had heart attack, stroke, bypass, stenting, but we can now identify high-risk people through imaging before they've had an event. Think the surfer I just told you about. If we identify these high-risk people, we also now have data telling us if we get LDL cholesterols down around 1.6 millimoles per litre or less, that over a period of time, approximately 18 months to 2 years, we can see plaque regression in over 50% of those people. So there is no question that cholesterol and coronary disease are related. There's no question that cholesterol of its own as the marker is not reliable. And in the confusion of the sharing of that information with people with vested interests, they've really besmirched the role of statins, which I think is unfortunate. We've had statins for 25 odd years, and they have made a remarkable difference to coronary artery disease rates in the States. I'm sure death from myocardial infarction has dropped as it has in other places in the Western world. And that is really at the feet of lipid lowering therapy. Now, the complexity around statins is that we tend to give them to people as they get a bit older. As we get a bit older, we get aches and pains, and we would much rather blame a tablet than recognize that we've got a bit of arthritis, or we've worked too hard in the garden, or we've got a pinched nerve in the spine. And when we look at the data behind blinding people to statins or not, we find that 75% of people who swear blind they can't take a statin, to such a degree they get enrolled into trials by their specialist physician, who obviously believes they can't take a statin, 75% of these people, when randomized in a blind way, will be able to take a statin without a side effect. which is quite compelling. There was a beautiful study called the Samson trial done in the UK by an Oxford group, only about 60 patients, but they did it over about 2 years. They had 3 bottles that they cycled people through. First bottle was an empty bottle, second bottle was a placebo, sugar pill, third bottle was a statin, and they did month on and rotated through. At the end of that time, they collated the data, which was from a daily app where the person recognized their symptoms on a scale. I think the scale might have been up to 20, 25, 30, doesn't matter. For the empty tube, the daily average was somewhere around 3 or 5. You're welcome to look up the Samson study. For the placebo, it was about 15. And for the active tablet, it was 16. And they offered the concept that there was a 90% nocebo effect, i.e. an intent to have a side effect from the medication driving that. So it's incredibly complicated. I had a wonderful German man who was so set that he'd never take a statin because of the pain in his legs. I examined him. We got an MRI scan. He subsequently had lumbar laminectomy, came back and had no problems taking his statin. So, you know, we are obliged to deal with the science, which is it really does work. We do need to recognize that people will have a nocebo effect. So it's a really important space, and I get to talk with people about it a fair bit.
Thank you.
Shania, go ahead. And also just correct me if I'm pronouncing your name wrong.
No worries, it's Shania. I'm a third-year health science student at Queen's University in Canada, so it's very nice to meet you both. Thank you so much for sharing so much about your background, like all the knowledge you've gained over the years. I think the importance of preventative cardiology truly cannot be overstated, and I think you both highlighted really well how rewarding it is to make a meaningful difference for patients, especially pediatric patients, as you mentioned. So I know you touched on CRISPR-Cas9. I was just wondering what other technologies in the field of cardiology that you're both personally excited about that are rising technologies.
Over to you, Joe.
Yeah, one of the things that I treat is it's called heart failure in children. So the pumping aspect of the heart has failed, and we've struggled to find very effective medicines for that. But we have some newer medicines now that we're studying that I think are really exciting. So I think it's great to have, and hopefully they'll be effective. But you know, for children, if they develop pump failure, heart failure, it's a real bad problem, you know, and they don't do very well. So, you know, to have this, you know, really exciting new therapies that are hopefully on the horizon is pretty exciting to me.
Would you like me to comment in that space as well, Shani? So, look, I'm going to dumb it down. I'm a very simple cardiologist, just an adult cardiologist. I haven't got the 3D brain that Dr. Rossano has for dealing with those complex childhood congenital issues. But my real hope actually is that we do better at prevention. And my efforts here in Australia locally are to really drive awareness of calcium scoring so that we just don't get surprised, and just so we know what's going on before there's a problem. We've got the technology. We can identify people who are at risk. We've got mechanisms for reducing that risk. That is cholesterol and aspirin and blood pressure therapy. We can put people under surveillance. In my heart of hearts, I believe we could almost eradicate heart attack. And that's extraordinary because in the Western world, it still kills 1 in 4 people. And of those 1 in 4, 20% of those people are 65 years of age or younger. And these are people who still have years to contribute. So humbly, I don't need the next great thing for us to make a massive impact on health in Australia. And I'm really trying hard to push the barrow here in Australia. I haven't got the resource to go over to the US, but I know Matt Budoff over there, who really is an exponent of prevention. And and one of the guys I look up to with an enormous amount of respect. But I think we really just do the simple things well is the most important thing for us to do. If we can scan people, get them on cholesterol-lowering therapy as appropriate, and then just get their blood pressure down and keep their weight down, we would make a monumental difference to the landscape of heart disease in our community.
Absolutely, that's very true. Thank you so much for all your insights. It's been really nice to meet both of you and hear so much important knowledge I think you're sharing. Yeah, thank you.
Thank
It's a
you.
pleasure. It looks like we're going to wrap up soon, Emiliano. I'd like to say it's been an absolute pleasure meeting you, Joe.
Yeah, likewise.
Yeah, really nice to share, and it's lovely because we've got two ends of the spectrum actually. And but whatever you do, we have a privilege as doctors to make a difference in people's lives, which is fantastic. For everyone listening, Emiliano, I would love to just let them know that those resources I've provided are incredibly valuable. I've included my first book as an ebook and an audio book. That's Have You Planned Your Heart Attack? Talking about cardiac CT imaging. I've included atrial fibrillation explained. That's an ebook and audio book. I've included cardiac failure explained, ebook and audio book, and I'll really flag for the preclinical years that cardiac failure explained talks about some of the renal physiology, which we remember, Joe, is complicated and a bit challenging. It breaks it down and it'll give people a really nice foundation to then build on. And I think we've even got a copy of Cardiac Rehabilitation Explained, plus access to my podcasts. I would love you guys to check into my podcasts. That's just Dr. Warrick Bishop on whatever platform you're using. If you subscribe, I would be certainly grateful. I drop in and out of the top 100 medical podcasts in Australia, so more subscriptions would be greatly appreciated. I get lovely feedback, so please check those out as well. Oh, and I've got an ECG aid memoir. I call it Rules of Threes and Fives. Check it out. Might be a really useful thing to just help you organize your thoughts around an approach to reading ECGs. We all need to do it, and it's a little approach I made up about 30 odd years ago when I was teaching nurses and young doctors. Thank you for the opportunity to share today.
Thank you. I also did believe, I think I saw one more hand. Siddharth, I think your hand was raised if you still had that question.
Yeah, thank you so much. Hi, I'm actually also in health science studying at Queen's University in Canada. Thank you so much both for being so open about your research and your experience as cardiologists. It's been really helpful and eye-opening. I wish I could turn my camera on, but I'm not home at the moment. But I wanted to make sure I still attended today. So I did have, I guess, a little bit of a specific question for patients that receive heart transplants. And this is both adult patients and pediatric patients. I've learned that their overall prognosis is lower and they have a lower life expectancy. Why do you think that's the case? Is it just rejection of the tissue, or is it susceptibility to infections, or is there another reason for it?
Yeah, I can take this. The short answer is yes, all of those that can cause that, and it's true. Certainly for a child, if they get a heart transplant, we would not expect to have a otherwise normal, life expectancy, living 70 or 80 years. Although people have lived 30 plus years, after a heart transplant, and so the full how long somebody could live probably still a bit unknown, but most sadly don't live that long. And it can be a number of factors, including rejection of the heart. People are more susceptible to infections and cancer. And then there's actually a type of coronary artery disease that develops in these hearts over time, which is a little bit different than classic, coronary artery disease that Dr. Bishop was talking about. And we have no effective treatment for that when that develops in a transplanted heart. And ultimately, that's what in the long term, is what prevents these hearts from lasting, 70 or 80 years.
Right. Thank you so much.
Yeah, sure. It's a great question. It's a great, if you need heart, it's really reserved for people that don't have any other therapies. And so in that case, it's a good treatment because people can live long periods of time and feel good and feel a lot better. But, unfortunately, it's just not a cure.
Look, there is a
Thank you.
technology in that space, and you may know more about it than me, Joe, but transgenic
Yeah.
pigs have been cultivated for consideration in this space. Again, I'll give that back to you, but I've seen, in fact, I think it was in Philadelphia it was first done. Am
There
I
was
right?
there's a lot of
Maryland?
interest in these sort of xenotransplants, these and having organs from other animals. They're sort of genetically engineered, and that could really be a game changer when it comes to organ transplant. So yeah, a lot of excitement that's going on in the field for that right now, for hearts and for other organs.
Well, thank you
Perfect.
both
Thank you.
so much. And I just wanted to say I put in like the community service Google Forms in case anybody's looking to receive those. Just fill it out and it'll be good to go. And also, Stephanie, I'm so sorry, but we're gonna have to wrap up just to be respectful of their time. But if you still have that question, I'm sure that they'd be happy to like give you their email and like, you can ask that question over email so you can have it answered. Um, but well, thank you so much for you both being here and have a good day or night wherever you are. And I hope to see you all at future Medical Marvels events. And thank you to the doctors for being here and answering people's questions and also just being on the panel. So thank you.
Thank you. It was a real pleasure. So thank you, Emiliano. It was great seeing everyone.
Thank you so
Yeah,
much.
thank you, Emiliano, and thank you, Joe.
Thank you.
Take care.
Take care.
Bye, everybody.
Bye-bye.